day as they need to. Let me see if I can share my slides. Not the greatest with Zoom, so okay, all right. So can everyone see that presentation now?
Yep. If you just want to put it in like viewer mode,
Yes.
then we'll be good to go.
Let me hit play slideshow. How does that
All
look?
right.
Does that
Looks
okay,
good.
awesome, good. I'm not the greatest at this. So if anyone has any questions during this, I'll probably not be able to concentrate and keep an eye on the chat. So either just interrupt me or we can go over some questions at the end. So this is as much as anything else, an interesting paper to me because of the questions that the thing that made me think about rather than kind of the content itself, because I think the content was a little bit slight, kind of necessarily by the number of cases that they had, and by the fact that it was retrospective, pathology samples. But it was a paper out of Bristol looking at glomerular ultrastructural changes and VEGF-A expression in diabetic cats. It's e-published on JSAP at the moment. So introduction, I kind of just present this a little bit out of order. But diabetic nephropathy, common cause of CKD in people, one of the most common causes, and it will occur as a sequelae to both type 1 and type 2 diabetes in people. I kind of quickly skimmed through the diabetic kidney disease chapter in Brenner and Rector, and certainly that's a really good primer if like me, you only have a very scant knowledge of CKD in diabetic people. It was kind of a good starting point for me, but certainly the progression of diabetic nephropathy does seem to be something that is perhaps worse in type 2 diabetic people, possibly associated with some of the other diseases that are also often comorbidities with type 2 diabetes, such as obesity and cardiovascular disease. And then I guess the debate as to type 1, type 2, how that correlates to our patients, we could get into a little bit. But there are essentially 5 stages of diabetic nephropathy, or diabetic kidney disease is the other terminology. The first 2 stages are going to be generally subclinical. So that's where we'll see glomerular hyperfiltration and hypertrophy, structural changes to the glomerulus, that will then progress into clinical changes such as persistent microalbuminuria, and that's the kind of typical early marker in people, is going to be the microalbuminuria, which can then progress further into more advanced kidney disease. So clinical nephropathy with more significant proteinuria and a decreased GFR, and then end-stage kidney disease. So as I mentioned, the first 2 stages of diabetic nephropathy are subclinical and are characterized typically by ultrastructural glomerular changes. So with the classic changes being thickening of the basement membrane, and that is kind of the hallmark of diabetic nephropathy. We'll also start to see changes to the endothelial fenestrations, the endothelial layer, and then also changes to the podocytes. So loss of the podocyte, so effacement, but then also changes to kind of slits, slit density, both in width and the loss of the number of podocyte slits, and then as a consequence, then getting mesangial matrix expansion. So diabetes in cats can result from loss of pancreatic beta cells and or peripheral insulin resistance. So I'm not an internist, I'm a criticalist, so I guess haven't gone quite into the weeds as much as far as whether we should use terminology like type 1 or type 2 diabetes. I think it's always a useful terminology when talking to owners, but I certainly know some of my internist colleagues try and shy away from using that terminology as it doesn't completely map onto what we would expect to see in people. Clinical diabetic nephropathy has not generally been recognized in cats, although there are some kind of limited reports. For example, there was one paper that I believe Dr. Langston was a co-author, which at least reported both microalbuminuria and proteinuria in diabetic cats. And certainly subclinical, that should be subclinical diabetic nephropathy kind of there's very, very limited studies. So there's some studies that have looked at a kind of limited number of samples for light microscopy changes, and they could not, the authors and I could not either find any studies that evaluated ultrastructural changes. So the goal of this study was really to look at those ultrastructural changes. So study population, this is essentially a retrospective study of pathology samples. So samples of cats that their, I guess, remains had been donated to or banked at the veterinary school at University of Bristol. As it kind of came up in the discussion, many of these samples were actually very old. So years, I think there was one cat that it was greater than 20 years old, and I'm not a pathologist, so as to how that length of storage, they didn't seem to think it affected the results too much, but I think that's, I'm not an expert in that to be able to comment too much. Essentially, the study cats were clinically diagnosed with diabetes, with serial elevated BG glucosuria and plus or minus fructosamine. I think they only had one patient for which they had serum fructosamine. The control cats were cats with non-diabetic and non-kidney disease. When we get to the discussion, although they don't really touch on this, I think it was an interesting choice to exclude cats with kidney disease. I guess from my perspective, I think it would have been as interesting, if not more interesting, in comparing cats with, diabetic cats versus cats with chronic kidney disease. So I guess it's a whether those samples were available. These are banked samples, so maybe they used what they had. And for the control cats, also, I guess, based on medical records, had not been administered drugs that would affect glucose homeostasis or kidney function. They don't go into more detail about that. It's kind of interesting because looking at some of the diseases that the control cats I guess, died of or had at present at the time of death, I would have thought some of these would have potentially been treated with steroids. So whether they were cats that, were euthanized when, for example, a cat was diagnosed with nasal lymphoma without any treatment. So they don't talk about that in any detail at all. And they certainly don't specifically say that, none of these cats got steroids or something else that I would have thought might be an important thing to note. I'm not a pathologist, so I'm going to be probably fairly light on my details about the electron microscopy, but essentially what I believe to be relative standard kind of fixation and processing techniques for the glomerular, for the TEM kind of evaluation. They looked at 2 to 3 glomeruli per cat with 6 images randomly taken of each glomerulus. The investigator that was evaluating the samples was blinded to the clinical data, and the measurements that they were evaluating were basement membrane width, the endothelial kind of fenestration density and width, and then also calculating the surface area of the fenestrations, and then looking at podocyte foot process width and slit width, and then also slit density. For light microscopy, again, the investigator was blinded to the clinical data. The samples were evaluated using previously published scoring systems. So this was the scoring system that Dr. Cianciolo and Dr. Quimby are co-authors of the paper from kind of 10 years or so ago. But they were looking at, and there's a scoring system for the percentage of normal parenchyma, tubule generation, interstitial inflammation, percentage of cortical scarring, and percentage of medullary scarring. For the VEGF expression, that was an immunohistochemical evaluation. They looked at a corrected total staining intensity of 3 glomeruli per cat. And then the mean for each cat was used in the statistical analysis. There were samples from 4 additional cats that were available. So there were 4, when we get to the results, for the VEGF, there are actually more available samples. And whether that was, I think, reading between the lines, I think there was lack of clinical data, so they weren't included in the main study. The study group, there was also in the discussion, sounds like there was a little bit of a disaster in trying to process some of these kind of stored samples. So whether they also lost, kind of couldn't do TEM on some of these samples that they had available for VEGF expression, because of kind of sounded like kind of subsamples that got significantly degraded in the kind of deparaffinization. So for the results, for the study population, they had 4 DM cats that were available for all analyses. So mixture of domestic 3 domestic short hairs, 1 Burmese, 2 each of male neutered and female spayed. 2 of the cats were in DKA at the time of their death, and one was 4 weeks, one was 2 months after DM diagnosis. So it's one, I think, factor when we come to the discussion is, will diabetic nephropathy become relevant in our patients just because of often the fairly limited time span from diagnosis to death in our patients. There were 2 non-DKA patients. The way it was reported was a little bit strange. They talked about 1 patient being euthanized, so they didn't say specifically, but my presumption was that the remaining 3 cats died spontaneously in hospital, but they said they didn't specifically state that. So there were 2 non-DKA cats, including the 1 cat that was euthanized 2 years after the diabetes diagnosis. So pretty wide range, which potentially does affect the results of, from diagnosis of diabetes to when the patient passed away. Quite a broad range of comorbidities, which some of them probably directly related to the diabetes diagnosis, some of them maybe indirectly, unclear as to, how, whether it's the comorbidity or the diabetes that was the cause of death in any of these patients. So the control cats, again, domestic short hairs, and then a couple of other species, 2 intact male cats, and then 1 male neutered and 1 female spayed. Again, had kind of a range of comorbidities. Again, wasn't entirely clear as to, I mean, I would assume in the control cats, given that they were non-diabetic, that it was the comorbidities that was the cause of death. But again, it wasn't specifically stated. Also wasn't stated as to whether these patients died or were euthanized. So this is the clinical kind of data. I do have for those of us that are kind of working in North America and are used to the milligram per deciliter unit. So as expected, significant difference in blood glucose in the control and the diabetic cats. There also a non-significant difference, although a trend in the creatinine from the control to the diabetic cats. Seemingly only one cat with, I guess, what we would call overt, I guess, whether you call it AKI or CKD in these patients. I guess only one cat with potentially a significant increase in creatinine. I think importantly, and I think this comes back to, I guess, I'm sure available samples, a pretty significant age difference between the control cats and the diabetic cats. So I think that's probably important. And again, it does make me wonder, as I said, the selection of the control cats. To me, I probably would have been more interested in kind of maybe an age match control of non-diabetic cats, whether they had kidney disease or not, might have had at least additional interest. But again, I don't know whether there was kind of limitations into samples available. This was obviously banked pathology samples, so potentially you've got to take what you can get. For the diabetic cats, they did have UPC results available, all of which were proteinuria. So all 4 cats were proteinuria. As I said, there were 4 additional diabetic cats that had immunohistochemistry performed for the VEGF. So there was 8 cats in total for which that data was available. Those cats were similar sort of age range, similar sort of, the median was similar to the other diabetic cats, although there was one very young cat. There was limited clinical data available for these cats. So I'm presuming that was the main reason why these cats were not included in the main kind of group of diabetic cats. So for the electron microscopy results, there was the GNC fenestration density and fenestration surface area was significantly decreased, but the width was not significantly different. There was not a significant difference in podocyte measurements. And the basement membrane width was significantly increased in DM cats. There was not a significant difference in the histopathologic scores between the diabetic and the control cats. And the VEGF-A expression was significantly increased in the diabetic cats. So that was all 8 of the cats that were available for that particular evaluation. So for the discussion, I won't go into some of the detail that they discussed, particularly things like looking at diabetic rats. I do tend to glaze over a little bit for those aspects. But essentially, characteristic diabetic nephropathy ultrastructural changes may be present in cats, even when the histopathologic scores are similar. So underlining the need for electron microscopy to be able to kind of pick up those early subclinical changes. Some of the diabetic nephropathy changes that have been noted in people were not observed in this study. So, for example, the endothelial fenestration width is often decreased in people. And possibly it was due to the small sample size. But the other factor, which they kind of touch on a little bit, is the time. So is it, often diabetic people could be living with their diabetes for many, many years. And so kind of that, they've got a much, or can have a much greater proportion of their life where they are managing their diabetes. So whether it's a matter of these cats just didn't live long enough to see some of the changes that are observed in people. So hard to tell whether true difference between DN in cats versus people, just due to sample size, and as said, the time progression of the disease. Some discussion of the role of VEGF-A. It's thought to be a big driver of the pathophysiology of diabetic nephropathy in people. And in people, one of the kind of hallmarks of early DN is that VEGF-A expression is increased. And then as the diabetic kidney disease progresses, it will often then decrease. So the fact that it was increased in these patients does kind of correlate with early DN in human diabetic patients. And the role of VEGF modulation as a possible treatment target was kind of briefly discussed. The limitations that they kind of discussed, and I've got some additional things that I would add. So limited sample size, I'm sure just based on kind of the samples that they had available and for which they had enough clinical data to be able to kind of include in the study. Probably a big one, as I said, is that age difference between the diabetic and the control cats. And as I said, the big thing for me is I guess, question the exclusion of kind of non-diabetic CKD cats, because I think that could have been valuable. Could have been either an alternative control population or at least an additional control population. Again, but this could have very, possibly related to samples available to the authors. They did talk about the kind of very long storage times, and again, as a non-pathologist, I don't really have too much to comment on as far as the effect that may have had on some of the outcomes of this study. Obviously, there was some sample processing issues which they described, where it sounds like they lost some samples just when they were trying to deparaffinize the samples for TM evaluation. So whether that kind of further limited their sample size by perhaps there was some cats that they couldn't then include because of the problems with processing the samples. So their conclusion was that diabetic cats may develop ultrastructural changes consistent with kind of the DN changes described in people, and also increased VEGF-A expression, which is thought to be a hallmark of so both the marker of diabetic nephropathy in people, but also potentially driving the development of diabetic nephropathy. They suggest that UPC monitoring should be routine in diabetic cats. I guess as a nephrology group, I don't think any of us probably would argue with that. We're probably measuring UPCs pretty routinely in most of the patients that we see. It's unknown whether diabetic nephropathy, so these early subclinical changes, will ultimately result in significant progression of CKD. Whether that's because it's not going to progress in the same way as it does in people, or cats just don't live as long with their diabetes and therefore don't develop time to or don't have time to develop a significant CKD. I think that might be something that, as we get better at managing geriatric cats, and I think certainly scarily it's almost 20 years since I graduated from vet school, which is slightly terrifying, but certainly, when I worked as a new graduate, we were thinking of as 10 or 12-year-old cat as a geriatric cat. Whereas now, when I'm kind of talking to owners, I think a cat that has, good healthcare can very commonly live in the mid to late teens. So we're certainly, I think, getting a lot better at geriatric care in our pets. Therefore, whether some of these kind of geriatric diseases will become more significant, I think is important for us to consider. So just because potentially it's not been significant in the past, it may be something that as we get better with managing geriatric patients will become more significant in the future. One thing which they didn't talk about, but which I kind of really prompted, which I think all of us are potentially interested in the role of SGLT2 inhibitors. But obviously, that the SGLT2 inhibitors in people has become a huge game changer for the management of diabetes, but particularly diabetes with CKD, and has hugely improved. This class of drugs has significantly improved outcomes in people. In North America, we do have 2 SGLT2 inhibitors available, so Bexacat and Senvelgo is one of it are available to us. Bexacat is a tablet. Senvelgo is a liquid. I don't have experience of using this in cats, mainly because, as I said, I previously a criticalist, so when I saw patients, they all had DKA. Diabetic patients, they all had DKA. Now, because I'm kind of exclusively managing nephrology or urology patients, I'm not really going to be starting my newly diagnosed diabetic cats. That's not usually a patient population that I'm seeing. The internists are going to be managing them. However, we have been using Bexacat as for additional kind of control of proteinuria in some dogs off-label, and that's so far in the patients that we've used that medication in has actually been, we've seen good results as far as control of proteinuria. So I think that's a kind of exciting class of drugs for us. I think of note, though, both of these medications list kind of needing insulin as a contraindication for using either of those medications. There's going to be, whether that's something that can be clinically helpful in patients that are also insulin dependent. In people, you would potentially be on both. But there is a challenge of the kind of euglycemic ketosis phenomenon that can be observed in diabetic people. So, but I think it's this paper kind of maybe at least think about whether we should be looking a little bit harder in our diabetic patients, kind of paying a little bit more attention to their potential development of CKD, and perhaps being a little bit more proactive with getting started on SGLT2 inhibitors. So if anyone's got any questions or any discussion, but as I said, I think the paper was a little bit slight just because of the data that they had available, but really prompted some questions for me.
Well, if no questions, then I guess we'll say thank you so much. And we'll see everybody next time.
Hey, thank you, everyone.
Have a good day.